I think this is very appropriate slide to start with, that we hope all for the best. And this is what sometimes the hiccups we come across. So I want you to say that at the end of the day, all you need is hope and strength. Hope that it will get better, and the strength to hold on until it does. And this is very important for this condition called cystic fibrosis, because we all live in hope all the time. We all have our ups and downs, but we should remain strong all through that period. So I wanted to say what cystic fibrosis is, and I think it's a very basic topic, but I wanted to build upon it. And given that we asked people to ask questions, and there were some excellent questions people had asked, I think it is relevant to still talk about the basics. And on the basics, we can then still very strong building in the future, inshallah. So cystic fibrosis is a genetic disease. And by that, it means that children are born with this disease. It never happens that somebody is born normal and then they get the cystic fibrosis. They always are born with this disease. As to whether they present at the beginning of their life or later on is a different thing altogether. But they genetically, they are born with the disease from the beginning. And it is called an autosomal recessive condition. And I just wanted to say that because I didn't know the words for those. And therefore, I'll put that in, and Dr. Zubia might help me with that. Recessive basically means that we need 2 copies in our makeup, genetic makeup, to have the disease. If people have 1 copy, then they are normal. So we need 2 copies, and it's called recessive for that particular reason. There is another condition called dominant. And when there are genetic conditions that are determined by the dominant genes, then you only need 1 dominant gene to cause the disease. But in this particular case, we need 2 copies. And these 2 copies, they come 1 from each of the 2 parents. 1 comes from mother and 1 comes from father. So it is not a blame game at all on any of the spouses. So this is happened because both parents carry the abnormal gene, but because they are only possessing 1 gene, they do not have any disease symptoms and they are normal. And when the combination of the 2 goes into the child, then they become, they have the disease. And it's called autosomal because each human body has 23 pairs of chromosomes, and 22 chromosomes are called autosomal, and 1 pair is called the gender, the sex determining chromosomes. So this is on 1 of the chromosomes that does not determine gender. And in fact, that chromosome is chromosome 7. So cystic fibrosis gene that goes wrong is located on this chromosome 7. Now, when the cystic fibrosis disease was first described in the literature back in 1938 by a lady called Dorothy Anderson, who was a pathologist in America, people knew previously that there was something that was causing the disease, but this was the first time it was given this name of cystic fibrosis. And through the family studies, it was known that you need 2 copies to produce this disease. But it was in 1985 that they actually located this gene on chromosome 7 of the human chromosomes. And then another few years before they actually located which part of the chromosome. So there are usually 2 arms of the chromosome. 1 is the long arm and 1 is the short arm. And it is located on the long arm of the chromosome. And it is this particular area here with the CFTR gene, which is responsible for it. So there are 2 copies of this mutation genes on these chromosome 7 that cause the disease. Now, as I said, we need 2 copies. And this is just to explain to people how this happens. So basically, there's a father, and green is the abnormal gene. And this is mother, who's got the abnormal gene. And if we can look at the combination, how these 2 abnormal genes or normal genes can combine together, you see that green from the father and this green from the mother, and becoming both green. And this is the way the child is affected. And there are then two chances that you get one green from one and one white from the other. And these are the carriers. So these are normal children, but they are carriers. And there's this particular one who inherits the normal genes from both parents and is totally 100% normal. So out of the possibility of 4 children, the disease happens in 25%, and this is the 25% chance of each pregnancy making this disease. So in each pregnancy, there's 25% risk that the child may be cystic fibrosis. And then alhamdulillah, there's 75% chance that the child is going to be normal, although there's a 50% chance, or 2 out of the remaining 3 normal ones, or 2 out of the 4, that they will be carriers but normal, and there'll be 1 person out of 4, or 25% chance of the pregnancy being perfectly normal. So it is risk in each pregnancy. So nobody can say that I've got 4 children, therefore I should have 3 normal and 1 abnormal. So it doesn't work for like that. So people can have 2 children or 3 children, I have known, who have cystic fibrosis, and there are people who may have all children who are normal. But each pregnancy carries the risk of 25% of carrying the disease onto the child to be born. Now, we know that Pakistan, they only check for one particular gene, and that is the delta F508 gene. Unfortunately, this is not very common in Pakistan. It's only about 1/3 of the population of Pakistan who carry this gene. In 2/3 is the other mutations. And to date, there are 2,090 different mutations like the delta F508 that can cause cystic fibrosis worldwide. So there's a huge number of different genes, and this is why people have different sort of presentations, different sort of severity, and difficulty in finding which particular gene people have impact on, because currently one particular gene. Now they started actually checking for as well in other genes as well. And these genes, detection of these genes can be useful in people who planning further children. So if somebody knows what the gene is in that family, then in the next pregnancy, they can actually use that information to see whether the baby to be born has got the disease or not. And then they decide whether they want to proceed with the pregnancy, or alternative, they may decide. Also, it may be useful because there are now medicines coming which are now very specific to some of the genes, and therefore it may be useful. But unfortunately, these medicines cost such a huge amount of money that they are not affordable by majority of the people in the world. Only the Western governments can afford it, even individuals and families cannot afford, and therefore it is very much dependent on the individual governments to support the patients in their country. And thirdly, as sometimes happens in our traditional families, that there are cousin families. So if somebody's got cystic fibrosis within the family, then it is useful to check the cousins who are likely to be getting married to see whether they carry that gene or not. So it can be useful, this gene detection, in 3 ways. 1, to treat the patient if the medicine is affordable and available. 2nd, for planning the future pregnancy. And thirdly, for cousin marriages in the future, to ensure that they know what risks they carry. Now,
excuse me, sir.
Yeah.
Can you speak a little louder?
Oh, you can't hear me?
Some of the people are saying that they cannot hear properly.
Okay, is that any better?
I hope so, inshallah, because I could
hear
before.
So I can hear you, and I hope you can hear me. Anyway, I'll try to move nearer. And
yes, thank you so much.
Okay, so as I said, this is a genetic disease. It's found all over the world, and it affects all social classes. So it's not just the poor who are affected, it's the rich who are affected as well. And I'll give you an example of our Prime Minister in 2006, Prime Minister of the UK, who had a son born to them in 2006 who had cystic fibrosis. So It is all over the world. And in the whole world, there are about 70,000 to 100,000, that's 1 lakh patients worldwide. Currently, it's probably about 85,000, the number between those two, because in all of the countries, including Pakistan and India and some of other underdeveloped countries, we actually do not know the number of patients who are present in those countries. So estimate is that worldwide, there are between 30 to 100,000 patients. And of those, majority are in the American states, accounting for about 1/3 of patients being in those countries, and about 20,000 being in Europe, and of that there's about 10,000 which are in UK itself. So we don't know what the number is in Pakistan because nobody really counts, nobody really knows how many patients there are in Pakistan. But we've got some evidence that this disease is present in Pakistan. And when I started work in cystic fibrosis 25 years ago, I saw the children from Pakistani background in our clinics. And that is what motivated me to then look for this condition and try to set up something for Pakistan. And the numbers of patients we can predict based on the community in the UK, we thought 1 in 10,000 people in Pakistan should have cystic fibrosis. Now, the population in the UK that settled in the two parts, Birmingham and Bradford, were mainly from Jhelum area, where when Mangla Dam was built, they were moved out of that area and they came and settled in these two cities. And down 3rd or 4th generation now, they've got cousin marriages, etc. as well, and the numbers of CF patients are known there. So it's a very small population or from a same one area in Pakistan that we are looking for. There are studies in other parts in America that suggested that the incidence can be 1 in 40,000. And I tried to get some numbers of children born in Pakistan each year. And this slide shows the number of births in 2013, 2014, 15, and 16. And that's on the left of the slide. And then if we were expecting 1 in 40,000, then at least about 125 babies should be born with this condition in Pakistan every year. And if we go by the estimates of 1 in 10,000, then we should get about 500 babies born every year in Pakistan. But really, we do not know what is happening to these children. We don't know where they are. We don't know how they are diagnosed, or we know where they're diagnosed, but we haven't got any records at all. Now, as I said, this disease is a multi-system disease. That means although there's a single gene which has gone wrong in the system, it affects many parts of the body, from the airways, the nose, the lungs, the liver, the gut, pancreas, and all the way to people who are not able to have children. And these men are sometimes normal all the way until they get married, and then they have difficulty conceiving or having children. And that's where they find out that they may have one of these mutations, which is related to cystic fibrosis, and that is the reason for that. So it can affect many people and many organs. Most commonly, however, as we all experience, it affects the chest and the gut. And that means that the people getting chest infections very frequently, and they get in failure to thrive, meaning not putting any weight on, they don't digest the food. And I'm just sharing some of the slides, which is actually data from Pakistan. So to make it relevant for Pakistan, rather than sharing my information from the UK, these are slides from Pakistan, and this is one Karachi from Ara Khan Hospital back 16 years ago, published in 2004. And when you look at it, it says 80.6% of the patients presented with lung problems. So this is 4 out of 5 children. When they presented with their illness to the doctors, they had lung problem. And 90% were the ones having problems with putting weight on. That failure to thrive means not putting weight on. So it's a huge, so majority of the patients in Pakistan at that time in that setting, they were either having recurrent chest infections or they were having problems with their weight gain. And that is usually through having diarrhea and not absorbing the food. This is another slide which Dr. Danish, who is part of our group and may be online at the moment as well. And this was published 3 years ago. And he looked at the children presenting to Aga Khan Hospital in, I think it was a 3-year period. And if you look at it, most of the time, they're presented with respiratory problems, that is lung problems, and gastrointestinal problems, and these are the gut problems. And when I looked at his paper in more detail, you can look at it and it says chronic cough. That was present in about 70% of the children at the time of presentation. So chest problems, whether it's a cough or whether it's a wheeze or pneumonia, they are one of the commonest causes of their symptoms at the time of presentation. Looking at that slide, the symptoms related to the gut are not very common. There are only about 11 or 10 patients, or 11 patients out of 43 who presented, according to that table, with the problems relating to gut. But when I actually looked at his paper in detail, it actually shows 86% of the patients presented with failure to thrive. So there was something, I think, I don't know, technically gone wrong with that paper, that in one in table, it's slightly different to what is set in the text. But I believe more of the 86% rather than the 11 out of the 43 people having the gut problems. And this paper is from Dr. Iqbal Bano from Lahore Children's Hospital, which again was published in 2017. And again, there are people, it says 10 out of 12 patients. There was 12 patients who had positive sweat test. And 10 out of those 12 patients, 83% had lung problems. And then 75%, that's 3/4, were the ones having difficulty putting weight on. So again, lung problems and gut problems were the main symptoms of children presenting with cystic fibrosis in Lahore area. This slide is from northern Pakistan. Again, we had, I think, 3 or 4 publications in Pakistan in 1917, which was excellent. And this was from Professor Ijaz in Rawalpindi setting. And they were doing these screening tests with sweat test in those children, and they did about 657, of which 22 were positive. And if one looks at the symptoms, again, the ones in green are recurrent pneumonia, cough, sinus problems, or coughing up blood. That made majority of the patients presenting with lung problems. And then if you look at the light blue one underneath, Meconium ileus and failure to thrive, that was another 3/4 of the patients who presented with those symptoms. So again, all the way across from Karachi to Lahore to Rawalpindi, the most common presentations people have with cystic fibrosis is chest infections and the gut problems with difficulty putting weight on. These are the other symptoms they can get. So we already mentioned they can get chest problems. We mentioned they can get failure to thrive, we're not putting weight on. They can get Meconium ileus, which is the obstruction of the gut at the time of birth. And that in Pakistan, in that last slide I showed you, was in about 4.5% of the patients, although in the West it happens between 10 to 15% of the cases. And then there is the constipated or obstruction in the later life of what's called the distal intestinal obstruction syndrome. And nasal polyps, which some of the patients in my group also have suffered from. And apparently there's a higher proportion in Pakistan for some reason or another. And then there's the conjugated hyperbilirubinemia, which is the jaundice. This is in the neonatal period, in the newborn period, that they have protracted jaundice. Rectal prolapse is another common, and in UK and the West, if they say any child who presents with rectal prolapse, this is the back passage falling out. Sometimes people call them piles or hemorrhoids in Pakistan. Then they can have similar condition. And we always suspect cystic fibrosis in these patients and do the test to exclude it. I mentioned infertility there, and usually happens in men, and they can present in the adult life even with that. And the electrolyte disturbances, which people were asking about questions in the group as well, especially in the hot weather when they lose a lot of sweat or when they get gastroenteritis and become dehydrated. And in some cases, as in our groups as well, there's a family history of cystic fibrosis, which we suspect that the other children may have cystic fibrosis and therefore start looking for it early. This is what I'm talking about, Meconium ileus. And I said in the West, it happens in between 10 to 15% of newborn babies. The children usually look very sick. Their tummy is all swollen up and they have vomiting and they don't pass any bowels at all. So they not open their bowels, they become obstructed, distended, they're sick, and they need operation. And with the operation, sometimes they are able to preserve their gut, and sometimes they lose gut, and they have what's called the short bowel syndrome, which causes problems in later life as well. But this happens in about 1 in 10 or 1 in 6 children in the West. But in Pakistan at the moment, it is happening about 1 in 15 or thereabout. This is a growth chart from one of my patients, who actually, if you can look at it, the bottom of the chart here, at the age of about 14, 15 months, they were well below the normal weight. This is the normal 50th percentile average, and they were well below that. And when they got the diagnosis of cystic fibrosis, you can see within 2 months, they started escalating their weight, and within about 8 months, they were on the normal line. So this is how these patients, after diagnosis, they respond to the medications with the creon and the other care and put the weight on. And this is something that unfortunately I don't see much in Pakistan at the moment, because they unfortunately carry on not putting weight on and having problems. But in the ideal situation, this is what we like to see, that if even they are below the average at the beginning with the diagnosis and the treatment, they should gain the weight adequately as shown here. And this, unfortunately, was the case in the UK, for example. This is a slide from 1949 paper, a child who was extremely thin and slim and not putting weight on. And children in 1940s in the UK actually died before they went to school as well. So this is the situation, unfortunately, not too dissimilar with what is happening in Pakistan at the moment. And that is what we got to aim for. And what in UK, what happened was, with all the basic care, never mind the lung transplant, never mind all these new medicines that are coming out at the moment, but it was the basic care that they were able to get, which is currently available in Pakistan, that made their children live longer. And this is my emphasis, that we need to do the basic care to get there. And then if the additional things become available, that will be the bonus as well. So let's not forget the basic care. And talking about presentation, this is where this lung is from a normal person, and this is lung X-ray from a person with a cystic fibrosis. All that markings, etc., you see, which is the hardening and blocking of the airways, which stops the air getting into the lungs, and therefore they have problems getting the oxygen into the body, and they get breathlessness, and their saturations are not so good. So how do you make the diagnosis of cystic fibrosis? Well, if there is somebody already in the family, then we should suspect, and any symptoms we should investigate properly. The test at the moment, we do sweat test and this is still the gold standard, although there's the gene mutations, but as I said, there are 2,090 genes, not all can be tested. And in Pakistan, there's only one gene which is commonly affected. So we can't rely on gene tests, but if it's available, then that is useful. But sweat test remains the gold standard. Even those children who have gene test positive, we do sweat test on them to see what that is doing. That is the clinical presentation along with the gene mutations and sweat test taken all together that we decide their management. So sweat test is the gold standard still. And unfortunately, the standards in Pakistan are not quite normal as yet. And I am doing a presentation to Aga Khan doctors tomorrow, and I will be highlighting that. But the standards are quite different in Pakistan as opposed to the rest of the cystic fibrosis. Again, the newborn screening is the other way of diagnosing children, and this is available in America and the UK and the West, and obviously not in Pakistan at the moment. So this is the other method of diagnosing cystic fibrosis. And then we can then check their pancreatic function, which is not a diagnostic test, but it helps to find out whether these children need the creon and pancreatic enzyme supplementations or not. So we can check that as we diagnose them with the sweat test or the gene mutations. This list goes through other systems like nose. They get nasal polyps with the respiratory problems. They can bronchiectasis with damage to the airways. They can get hemoptysis, which is coughing up blood, or they can get pneumothorax, which a couple of patients in our group have unfortunately suffered from, and they know what it feels like. There's the gut problems, failure to thrive, short gut syndrome I mentioned, which is with the Meconium ileus. Liver problems, CF liver disease, cirrhosis, which is shrinking of the liver and failure of the liver that sometimes then requires liver transplantation. Pancreas causing CF-related diabetes, bones causing osteoporosis and fractures, and infertility, and many other systems that can be affected in cystic fibrosis. So as a doctor, when children come, we need to screen for those things, to anticipate these things, ask the questions, the right questions, and then make sure that we can do something to prevent them happening in the future. Unfortunately, 80 to 90% of the CF patients, they die of respiratory failure or the lungs not working. And this is what their X-rays towards the end look like, or their lungs look at post-mortem. And this is what we want to avoid. I know we have had 2 patients in our group, one adult and one child, who had lung transplant. And yes, they get better, but my message to the group and all the CFA patients is that we need to do things to stop getting to this stage where, as a child in particular, we are thinking about lung transplantation. To me, that is a failure of treatment during childhood that we've come to that. Yes, there are adults who need it, but not many adults actually make for it or need it in even adult. So children and people who thinking that, oh, it's okay, we'll get lung transplant, that is not what I want. That's not what we want as the professionals. And we need to make sure that we can get their chests a lot better to get into that stage in the first instant. And this slide shows that the survival in the West went up and up. And currently we are living, our CF children on average are living age of 40 years. And that's a huge improvement. And this is mainly before all these new medicines came. And along with the multidisciplinary team people, with the nebulizers, with the creon, and with the antibiotics, we've got to that stage. And I want to see these children get into that in Pakistan as well. And when the other medicines and other facilities come along as well, inshallah, things will get better from that on as well. But at the moment, we need to do all the basic things that the West did to get this survival better. And at the end, as I said at the beginning, is a hope and strength. And we strongly believe in Allah and in His mercy. And therefore, we need to carry on hoping and working hard to stop our getting children bad to the state that we have to get them transplanted or have to regret that they are not with us anymore. And with that, I will stop at the moment, and I will, in a couple of minutes, open up my other slide and I'll answer the questions that people had already asked in the group. And Dr. Zubia would hopefully be taking any of the questions arising during this presentation, and then I can go through those questions at the end as well. So I'm going to stop this slide and close this, and I'll open up my other slide, which is the questions people had posed in the group, and hope to see you in another 30 seconds. So Dr. Zubia, you probably got your mic on. Can you hear me still, please?
Yes, we all can hear you.
Yeah, and you can see my slides have changed.
Yes, your slide is related to question and answer session.
Okay, so I don't know how many people have asked the questions in the group.
Only one question is asked in the group. So you can answer the question which you have already. So we can answer this one at the end, inshallah.
Okay. So what I need to do is I need to go through the questions that people had already asked in the group, and I will go by the question, the order in which they were asked. And first question, the first question, and I hope that the people who have asked the questions are listening at the moment, was by mum of Noshwa from Kuwait. And it was to do with which tests at early stage can confirm the diagnosis of cystic fibrosis. And they also asked the question, how much can we rely on these tests if the mutations are negative? Now, just to answer the first question, that at what stage can we confirm the diagnosis and which tests? Now, as I said, this disease is actually present from birth. So children are born with disease, and therefore the tests can be done from birth onwards. And gold standard test is the sweat test. That sweat test is performed when child is able to produce enough sweat. And that may be dependent on the amount of sweat that is required for the test, and that depends on the machinery the hospital may be using. I remember in our own hospital, we used to require 100 milligram of the sweat to measure the sweat properly, sweat chloride properly. Then with the acquisition of the new machines, that amount came down to 14 milligrams. So from 100 milligram to 14 milligram. And I know some of the machines in our hospital or in some of the parts, they require about 70 milligram sweat. So it depends on which machinery you're using. If they are able to get adequate sweat test, then that sweat test can be done at any age. Usually child is about 4 kilo in weight or above that for that test to, or for that size baby to produce enough test. So one needs to make sure, has the child got the symptoms, and do the sweat test. Fecal elastase 1 is the test that we can also do to look for pancreatic sufficiency or insufficiency to see whether they need creon or not. And that is not a diagnostic, but it's a supportive test. And then there's the gene mutations that can be done. But as I mentioned in the presentation, the only common gene that is tested in Pakistan is delta F508, and that is only present in 1/3 of the patients, and therefore 2/3 of the patients will be negative for this gene and therefore not that useful. So I think tests are available from birth onwards, but their reliance is very much dependent on the technique, the machinery, and the amount of sweat or the gene mutations or the number of mutations people are doing. When doing these tests, people need to know why they're doing it. Unfortunately, sometimes people do the test, and that could be on the X-ray or blood test, without thinking the reason why they've done it. And sometimes you do get the odd abnormal result or outside the normal range, and then people are starting wondering why we've done this test and what does it mean. So the reliability of these tests dependent on the clinical information as well. So don't do any tests without any signs or any problems unless you suspect there's a genetic disease or family history, or you know there's a sibling who's affected. So the clinician or the doctor who's ordering the test must know the reason for testing, and they should also know the limitations of the test within their own laboratory. And they also need to consider the alternative explanations if these tests either come negative or positive. Even the sweat test, there are conditions that can produce abnormal sweat test, but not necessarily due to cystic fibrosis, but to the other conditions. And therefore, for example, malnutrition. So if somebody, and this malnutrition we said is very common in CF patients. So if somebody, a baby is very malnourished, their sweat test can be actually negative, even if they got cystic fibrosis. Or sometimes people may be very edematous, and babies get edematous as well because they may have low protein or kwashiorkor, which is one of the conditions with malnutrition, and they can be negative in that condition as well. So it is important to know the clinical status of the child to interpret the result. And other thing is that Pakistani laboratories are actually not doing what's called the quantitative sweat test. They are doing what is called the conductivity test. And this is different. And conductivity test is used for screening purposes. And you will remember I asked people in the group to tell me if somebody have had their tests done recently to see what test people are using. So those who from Aga Khan, if you look at your reports, it actually reports conductivity test, and its range is also different. And it says that this is a screening test. Even on their reports, it says a screening test. And I remember I had asked 1 or 2 patients to go back to Aga Khan Hospital and ask them, can you please do the quantitative test, which is the proper measurement of chloride rather than the conductivity? And they said they don't do it. Similarly, when I was talking to Children's Hospital in Lahore and I said, what test do you do? They said, we do quantitative test. And when I looked at their reports, they actually do conductivity test as well. And same, that paper I quoted from Rawalpindi, they do conductivity test as well. So nowhere in Pakistan, the quantitative test is being done for the chloride. It is all conductivity. It's a separate debate altogether whether conductivity test is okay and can be used. And there are people who says, yes, it is reliable and can be used. But at present, the Cystic Fibrosis Foundation, the United States Cystic Fibrosis body, and the UK CF Trust, they do not accept conductivity test as a diagnostic test. It is a screening test. That means it makes you suspicious that child may have CF, and therefore one has to do either the gene testing, which should have most of the genes mutation tested, or the proper sweat test with quantitative test. So I think that is something.
Excuse me, sir.
Sorry?
Yes, I just wanted to tell you that we received now during when you started to answer this question, then after that we received 7 more questions. So we have, after you answer these questions, we have 8 questions in line.
Okay, thank you very much for that update. We'll just see how things progress. So that, I hope I've answered the question to Nashwa's parents, that there are tests that we can do at the beginning, and reliability depends on the clinical status and the tests, laboratory reliability on their standards, internal laboratory standards and external standards that they do. The second question was from the parents of Zainab from Islamabad. And this was said, what are the earliest symptoms of cystic fibrosis? And same question was asked by Ali Akbar, who is our great man behind the network and facilitating these talks. And I think I may have covered part of that answer to that question within my presentations, that different genes cause different symptoms, and interaction between different genes, or what's called gene modifiers, or their environment, can also change the presentation as well. So what are the earliest symptoms of cystic fibrosis? If, for example, one was suspecting that baby to be born even during pregnancy may have cystic fibrosis, so antenatal scans can show abnormality with what is called hyperresonance, and 9% of those children can have cystic fibrosis, and that was in one of the French studies, but obviously Pakistan will be much less. It can then present at the age of birth with Meconium ileus, and that is the earliest they can present in after birth. And in UK and the West, 10 to 15% of the patients can have Meconium ileus, but in Pakistan, the percentage is about 5%. They can present with jaundice at the neonatal period, early childhood, or recurrent chest infections, and not putting weight on being the commonest, and that can present from birth, or it could be any time during early childhood. If they had gastroenteritis, they can present with abnormal electrolytes, rectal prolapse, as I mentioned, or nasal polyps, or infertility in adult life. So the presentation can be from day one, or even before pregnancy, if one was looking for it, or in adult life. So it's a variable, and that depends on the different mutations and the clinical setting of these patients. So I hope that question is also answered. And then the next question was, is genetic testing for mutations other than Delta F58 available in Pakistan or not? The main, I think, answer to that is no, it is not available all over Pakistan. Currently, only Delta F508, and that is only in some places and not all over the Pakistan. But that again only accounts for 1/3 of the patients. 2/3 will remain undiagnosed if gene mutations were used for the test. But I know Araka is currently promoting a larger panel of mutations. I'm not sure how many panels, but they may be doing about 40 or 50 mutations that might pick up some of the patients, or more than just the single gene. And I have facilitated some mutation testing in Lahore through one of my contacts through there. So if people want it done, then I think our costs about 40,000 rupees, if I'm correct. It may be more nowadays. And the ones I facilitated at the Children's Hospital was free of charge because it was funded by some other bodies. And I may be able to help people if they live around Lahore area to facilitate that as well. So yes, I can sort of help with that and see how things go. But at the moment, there is only one mutation that is available in Pakistan.
Assalamu alaikum, Dr. Ali Akbar. This is Dr. Danish from Aga Khan Hospital. So in Aga Khan, we are still not doing, only one, this one, Delta 508. We are not doing any other mutations. And another institution in Karachi, this is NIBD, that is doing other mutations. So not in Aga Khan, still we are working on it.
So NIBD, is that doing free of charge or is that charging?
It's charging 40,000 to 60,000 around, and he's charging, yeah. They're charging.
Okay, so that was my impression. Somewhere in Karachi, they were charging about 40,000 rupees or so to do the tests. But so it is available, but it may not be affordable by most people. Okay, so next question was from Sargoda, parents of Abdullah. And they were asking about the sweat chloride. Is the amount of sweat chloride in sweat related to the severity of the disease? For example, is 130 worse than 100 or vice versa? So I think it was an excellent question. And there's been some conflicting reports. As you know, that we use this sweat chloride for the diagnosis. And we know that in the quantitative setting, not in the conductivity, but in quantitative setting, anything over 60 is positive. So anything less than 60 or 30 to 60 in the newborn or infancy, and 40 to 60 in older children is doubtful. And we need to make sure we're looking at their experience and clinical symptoms to decide what is happening before we make the diagnosis. So it is something that is still debated, but I personally believe that yes, the level is related to the severity. And the reasoning for that is, one, we have got cutoff points for the diagnosis, and there'll be no cutoff points if it really didn't matter. Second, now with the new medicines for cystic fibrosis, people are actually repeating the sweat test to see if this is normalizing, and we are using the response to medication measured by the sweat test. So therefore, if the medicines are making people better, then the sweat test, sweat chloride comes down. So I think, yes, it is related to the severity of the disease. Although there are some publications which said that it is actually not related. So next question is from Multan. And they asked if the cousin marriage is the only cause of cystic fibrosis, or is there something else that causes cystic fibrosis? As I mentioned, it is a genetic disease. It needs one copy from each parent to cause the disease in the baby. So therefore, by definition, you need to have two carriers. As at present, you can have affected parent as well, which sometimes affected females can have children as well. But it is a genetic disease. And the prevalence or the incidence and possibility of cystic fibrosis happens very much how common that gene is in that population. So in the UK, for example, 1 in 25 white people walking along in the street, they are carrier. They carry the gene. And the probability of two people getting married and together, those are the two carriers getting married, is 1 out of 625. And then the chance of them having a child is in each pregnancy is 1 in 4. So overall, there is 1 in 2,500 births that we suspect will have cystic fibrosis in the UK. That in Pakistan is going to be less common because the carrier rate is less. I think it's around between 1 in 50 people in Pakistan may be carrier to 1 in 86 people, depending on whether it's 1 in 10,000 or 1 in 40,000 as per the UK or the American studies. So the incidence is going to be much less. However, that abnormal gene within a family, if present, is likely to be commoner in the cousins. And therefore, if there's a cousin marriage, then the possibility of them having children with cystic fibrosis is higher compared to the rest of the population. But if in the ordinary population, two carriers, they got married, and within the family, two cousins who are carriers got married, the pregnancy chance of resulting in abnormal baby is still 1 in 4. But obviously in the outer world, the bigger population, there are fewer people with the genes rather than within a family. So yes, it is likely to be more common in a family with cystic fibrosis already present than the ordinary population. But it is only by the two abnormal genes coming together that causes the disease and not any other process. I hope I've answered that question reasonably okay. And then we got next question from Sragoda again, from Abdullah's mom, asking about, is the tummy of CF children more swollen compared to children who don't have cystic fibrosis? Again, very good question. And the answer really lies in at what stage are we talking about? As I mentioned, even at birth, 10 to 15% of the children can be born with what's called Meconium ileus. This is obstruction of the gut, and they will have abdominal distension, and they'll be sick children. So they will be diagnosed at the time of birth. And then there are other children who may have obstruction through constipation or constipated bowel later in life, what was called the distal intestinal obstruction syndrome, or Meconium ileus equivalent, and that happens in older children. So that can cause, so any blockage of the gut, whether it is the time of the birth or later in life through constipation, or another condition which is common in children, which is called intussusception, where part of the gut actually goes into the gut and causes the blockage, that will cause a tummy obstruction as well. then we know that CF children can get liver problem as well. And liver can get large to begin with, it then becomes cirrhotic and shrinks, so they can get abnormally distended tummy through large liver. Or the liver causes what's called portal hypertension, and the spleen in the spleen in the tummy can get bigger. That can cause obstructed, not obstructed, but distended abdomen. And then sometimes with the liver disease, the protein level can drop, and these children can get edema or the swelling or what's called ascites, accumulation of fluid in the tummy, which can cause obstruction as well. But most commonly, given take away these surgical problems and obstruction problems, the CF patients commonly do get distended abdomens, and that is through the gaseous distension. This is the gas produced in their gut, because sometimes you get frequent use of antibiotics that can change the bugs sitting in the abdomen, and they can break down the food that we eat and produce a lot of gas as well. So gaseous distension and bloatedness can cause the swelling of the abdomen. And if, for example, people who have had Meconium ileus and had their gut resected or other problems, they can get what's called blind loop, the loop sitting there with bacteria that produce gas. And sometimes in CF, the gut actually doesn't move as much or as well as the normal gut, and therefore can become distended. But not all distensions are very important or serious. So yes, abdominal distension occurs in children. Quite a lot of time it's due to the gas, or maybe creon not enough, or different bugs or antibiotics doing it. But when child is looking sick and vomiting and they're not passing any poo, that means there is obstructed bowel, and that has to be seen by the doctors to make sure they're not dealing with obstruction that needs surgical answer. So next question was from Sarah, and I was so pleased that this question came from Sarah herself. She sent an audio message in the group asking this question, that does every patient with CF have asthma? I thought that was a little bit of a very clever question for a girl of young age, just turned 9 a few days ago. So to answer that question, the answer, does every single patient with cystic fibrosis have asthma? The straight answer is no. But there are always but in medicine and cystic fibrosis. Children with cystic fibrosis are 3 times more likely to have asthma than the normal children. So whereas in the UK, for example, about 10 to 15% of ordinary population have asthma, our CF children in the UK is about 30 to 34, 35% of children who have asthma symptoms. Now, what is asthma and what is CF? And that is really difficult, because in Pakistan or other parts of the world where CF is not commonly found, the CF symptoms of cough and the wheeze are similar to what the asthma patients do. Asthma patients, additionally, if one wants to differentiate between them, the differentiating features are they have other features of what's called atopy. That means they have hay fever, they have allergy to pollen when the weather is out there, and grass pollen, tree pollen. Then they get hay fever, runny nose, runny, itchy eyes and nose. And also they get eczema, which is the skin condition. And that may be present either within that child or within the family. So the presence of asthma, eczema, and hay fever make the wheezing more common and asthma more common in that individual. But in CF patients, they actually do wheeze, they do obstruct with secretions and inflammation that causes the muscle spasm, and they do respond to the asthma treatment with the bronchodilators such as Ventoline. So yes, not everybody with CF has asthma, but 1/3 of them do have, and it is the doctors who need to take detailed history and listen to the patient and see the response to medicine to decide what is the underlying cause. Is it CF asthma or is it asthma and not CF? Next question again came from Kuwait. Nashua's parents asked, is it possible that the doctors find out about the disease and they don't, I think, let me just have a look at the question again. My screen is hidden with the other thing. So is it possible that the doctors find out about the disease at the age of 6 years, and all these years the child lived normal life without any medication? So straight answer to that question is yes, it can happen. As I mentioned, there are some male adults who are perfectly normal and they only find about their cystic fibrosis when they get married and they can't have children. I believe Nashwa is 7 years of age, and she's probably been well until 6 years of age, and then had chest infection and got diagnosed with cystic fibrosis and ended up on the treatment. And she's had the mutation test done, I believe, which was negative. So I believe that with that negative test, with no symptoms for 6 years of life, and currently probably not on much medicine, she probably may not have cystic fibrosis. So it could have been a false positive sweat test at the time of testing that she got labeled as CF. But answer is yes, you can have CF symptoms, not necessarily at birth, at any age. And some of the tests can be false positive or false negative. So things got to be taken hand in hand with the clinical symptoms of the patient, the tests. And this is why I said the doctors who ask for the test, they need to make sure they know what test they're asking for, why they're doing it. They need to know the limitation of the test, and they need to know the things that can give positive tests or negative test as well. So I hope I've answered that question. And then the last question that I received on the system, on our group, was from Khadija, sister of Sarah. And I'm not sure whether Sarah's mom was feeling a bit shamed asking questions, being a doctor herself, and that's why she asked the kids to ask them. I don't know, she can answer. But Sarah's sister Khadija asked the question that when a child is stable with no exacerbations of any symptoms, then how frequently do they need to be seen for the follow-up? Very good question indeed. And I just want to spend a couple of minutes on this question purely because I believe prevention is always better than cure. And lots of things that I preach, and I've been preaching in this group, with asking the parents to do the physiotherapy regularly and do other things, and good nutrition, is actually to make sure we can prevent the complications of these diseases later on in life. So recommendation, say by the UK CF Trust at the moment, is that all children with cystic fibrosis should be seen every 2 months. And no child should go without seeing a doctor more than 3 months. So we make effort and we are judged upon it, and we get penalized if our patients are not seen in that time scale. So we see all our patients every 2 months to every 3 months, and they are seen by the multidisciplinary team that includes the dietitian, that includes the physiotherapist, the doctor, and the pharmacist, and also a clinical psychologist or social worker, depending on the needs of that family, and see how things are. So we measure their height and weight every time they come. We do culture on every time so that we know what bugs they are growing. So if there is difference from the last one, we know what antibiotics to give to prevent any lung damage. We check their height and weight to make sure they're putting the weight on regularly. We review their creon to make sure they're taking the creon appropriately, their diet and calorie intake is okay. And all these things are to prevent things happening in the future. I've been asking people in our group to say, at least please do every 4 months as a culture, so we know what bugs we're growing. So if they get the symptoms, at least we can treat with appropriate antibiotics. So to answer your question, yes, I think very important to see the doctor and the other team members, because physiotherapy is very important, dietitian is very important, and it's a teamwork. We need to work together to prevent things happening. And if there is any complications of the disease happening, the liver disease or diabetes, etc., then we can detect it at an earlier stage and take it further. But it obviously, I can understand the situation in Pakistan or other parts of the world. We may not have CF centers, we may not have multidisciplinary teams. Affordability is a big factor as well, that it costs a lot of money, and maybe the distance traveled by the families to go to centers, it may not be possible to go and see the doctors every 2 months. So what I want to work with the doctors in Pakistan is actually to see if we can do some educational things, and this is also for the sake of the patient in this particular talk, to see if we can in the future develop something to prevent things happening rather than just treating the illnesses or pneumonias as they happen. So I hope Khadija is satisfied with my answers. So that is all I had received online. And if I just now come out of my presentation and we can answer any of the questions the families may have asked during the presentation itself.
Yes, can we start with these questions now?
So please fire away.
All right. So one thing which I want to make clear to all the participants, that so far those questions are answered which were already being asked in the group, because they were being impatient that why our answer is not still, question is still not answered. So now we'll start with the question which were posted, and most of the questions are posted when you started answering the questions. Anyways, the first question is asked by Lubna Sadiq, and she is asking, is it really required to do sweat test when we already have done gene mutation?
Okay, I think this is from Lahore, a question from Lahore, I can guess. So I think sweat test, as I said, is still the gold standard recommended by the CF Foundation in USA and the UK CF Trust in the United Kingdom. Even those people who have gene mutations confirming the gene diagnosis, we still do the sweat test on those. And the reason for that is, one, that we still sort of consider that as a standard test, and also secondly, because of the new medicines that are now becoming available, and to see their response. Sweat tests are done every 6 months on those children to see how well they are responding to the treatment. So it's a different setting. If, for example, a child had a gene mutation, delta F508 homozygous, i.e. they got 2 copies of that, then genotypically, they've got the diagnosis. If they got the symptoms, they don't need the sweat test. But if they were going to get the treatment, the new treatments for the cystic fibrosis, and they wanted to see the response to that treatment, then yes, they may be having sweat test in the future. So I think in Pakistan at the moment, as I said, delta F508 is the only gene which is most commonly checked. That only picks up 1/3 of the patients. Therefore, 2/3 of the patient will be missed if we only relied on gene testing and not on the sweat test. But if the 2 mutations have been found which are CF causing, then sweat test, in my opinion, becomes less relevant if the patient has got symptoms of cystic fibrosis. Is that okay, Lubna?
I hope it's okay, inshallah. The second question, I don't know the cities because they didn't mention, but the question is from Quratulai, and she's asking that if a child is coughing up blood every week, what medicine should be given and to get rid of it?
Okay, so this is mom of Zainab from Islamabad. Thank you. So basically, cough it up. This is called hemoptysis, and this is common in children with cystic fibrosis who have chest infections. And basically, with chest infections, the lining of the airways is damaged, and with time, they develop a condition called bronchiectasis. Now, if that damage of the airways extends to involve the vessels, small capillary vessels or large vessels, then depending on the caliber or the size of the blood vessel involved, they can have small bleeds or they can have large bleeds. Sometimes it can be pneumonia. Children with no cystic fibrosis and they have pneumonia, they can cough up blood as well. So it's the inflammation in the airways that can leak a little bit of the blood. And in children with cystic fibrosis, they get cough quite a lot, so the pressure increases in the lungs as well. That can cause the bleeding as well. And in children, we tend not to see what's called the massive disease, massive hemoptysis, or large amount of blood. And that is usually like a cup full of blood. We don't see that. But if there's a large vessel involved with bronchiectasis with older children, then that can happen. In younger children, it's usually streaking of blood, which usually settles down by itself. Now, that is one mechanism that I've described, damage to the airways and infections that cause bleeding. Second thing that can contribute to that bleeding is what's called the clotting ability of the individual. Now, clotting factors are made in the liver. So if somebody with CF liver disease has abnormal clotting, then that may make them prone to bleeding, and they may not have huge damage to the airways, but with pressure of the cough, etc., they may bleed as well. So when considering bleeding, so there's the lungs themselves with infection and bronchiectasis that can cause erosion of the blood vessels within the lungs that can cause bleeding. Secondly, the CF liver disease can cause bleeding. And thirdly, there are platelets in the body that control bruising and bleeding. And if for any reason, sometimes viral infections can express what's called ITP, idiopathic thrombocytopenic purpura, then that platelet count can also contribute to bleeding as well. So there's those three main things that can cause bleeding. As to what one should do when they have the bleeding, obviously one needs to see the child clinically, and if we have their liver tests done previously, or their full blood count done previously, or we know their x-rays or CT scans that show bronchiectasis, then one may be able to say which of those three components is contributing. And then we need to take those things accordingly. Now, if it's somebody coughing hemoptysis, then one of the things one needs to stop is anything that increases the pressure within the lungs. And this is things like CPAP, people who have a cappella or things that increase the pressure, because they are going to increase the bleeding. So we need to stop those things, and we need to have gentle percussion, tapping type physio to clear the lungs. Secondly, anything that's going to irritate the lungs, that is hypertonic saline or anything like that, which is fumes, smoking, and that sort of things, which is going to make child cough, we need to back off from that as well. So thirdly, that maybe we do the test and see if the platelet count, clotting is okay.
Excuse me, sir. This, sorry to interrupt you. This Kuratul Nayan, she is asking that my daughter is 15. So what test should I do for her in specific? Should we answer it here, or we can leave it for clinical?
So I mentioned the full blood count, look for platelets. I've mentioned the liver test, look for coagulation screen, and pointing towards the lungs. And from the lungs point of view, it depends. It's a small amount of bleed or large, whether there's a CT scan or whether we need angio done to see if there's a large blood vessel, if that is the specific question they want to ask. I was just trying to see how to prevent it and how to stop it when they stop bleeding. But if they are happy with that, then we can go on to the next question, please.
Okay, thank you. Next question is from Rizwana Shaheen, which you have already answered, because the similar question like about the cousin marriage and marriage outside the family. Then fourth question, so we can dismiss that. The fourth question is somebody who did not enter by the name, it's Galaxy something. So the question is in Urdu, so we'll expect an answer in Urdu. कि क्या कोई वे है कि स्वेट कम आए बच्चे को, कोई ऐसी मेडिसिन के जिससे स्वेट कम आए बच्चों को?
एक तो ये बात है कि बच्चे को स्वेट कम करवाना क्यों चाहते हैं. मेडिसिन हम ऐसी नहीं देते हैं, ना किसी ने आज तक ली है, क्योंकि ये बच्चे सिस्टिक फाइब्रोसिस स्वेटिंग इनको ज़्यादा होती है, बिलहसूस जब बुखार होता है इन्फेक्शन के साथ, वायरस इन्फेक्शन हो या चेस्ट इन्फेक्शन हो या मौसम के लिहाज से, तो मेडिसिन हम नहीं दे सकते कोई ऐसी कि जिसको इसका स्वेटिंग जो है ना वो स्टॉप करे. स्वेटिंग बेसिकली ये बॉडी का नॉर्मल रिएक्शन है टू रेजिंग टेम्परेचर विद इन द बॉडी। तो जब बच्चों किसी को बुखार होता है तो स्वेट होता है, तो स्वेटिंग से बॉडी कूल होती है। तो अगर हम स्वेटिंग को स्टॉप करेंगे तो वो हीट जो है अंदर ही रहेगी, तो वो जो है वो मैलिग्नेंट हाइपरथर्मिया कंडीशन होती है कि बच्चे का बुखार तेज होता जाएगा और बहुत डेंजरस होता है। तो स्वेटिंग को प्रिवेंट नहीं किया जाता, बल्कि स्वेट जब भी होता है, मुझे याद है पाकिस्तान में कई दफा जिन लोगों को बुखार होता था वो चाय गर्म पीते थे, ऊपर रजाई लेकर सो जाते थे, स्वेट आता था तो उनका बुखार उतर जाता था, बिकॉज दैट इज बॉडीज नेचुरल वे, कुदरती उसका है तरीकाकार अपने बॉडी को ठंडा करने का। तो वो ऐसा नहीं किया जाता, बल्कि हमें जो ग्रुप में हमने आंसर किया था कि अगर किसी को स्वेटिंग ज्यादा हो रही है तो उसकी सॉल्ट जो लूज होती है उनको, और फ्लूइड इनटेक जो बच्चे की है वो बेहतर करना चाहिए, प्लेंटी ऑफ फ्लूइड्स टू मेक श्योर कि वो डिहाइड्रेशन ना हो, और उनको सॉल्ट, एडिड सॉल्ट देना चाहिए ताकि जो स्वेट में सोडियम लूज हो रहा है वो रिप्लेस हो जाए, बजाय इसके कि स्वेटिंग जो है उससे किसी मेडिसिन के साथ स्टॉप किया जाए। Next question.
Okay, thank you so much. The next question is from Shazia Parveen. कह रही है कि क्या नॉर्मल बच्चों को टेस्ट करवाना भी जरूरी है? I think she mean the normal siblings.
तो जैसे मैंने कहा कि अगर एक बच्चा घर में जिसे सिस्टिक फाइब्रोसिस है, तो अगर उनके दूसरे बच्चे भी हैं तो 75% चांस है कि वो बच्चे दूसरे इंशाल्लाह ठीक होंगे। सिम्टम्स नहीं है तो ठीक हो सकते हैं, लेकिन जैसा कहा कि दफा सिम्टम्स बाद में होते हैं, तो हम जो है ऑलवेज ऑफर द स्क्रीनिंग ऑफ द सिबलिंग्स इन दैट फैमिली, जस्ट इन केस कि वो बच्चे को अभी सिम्टम्स नहीं है लेकिन हो सकता है कि उन्हें CF हो, तो इसलिए वो किया जाता है। सेकेंडली जो है फिर उन बच्चों को पता होता है या उनके पेरेंट्स को पता होता है कि ये कैरियर है या टोटली नॉर्मल है, तो उनके फिर आइंदा इन पर्टिकुलरली हमारे पाकिस्तानी सेटिंग में यू कैन देन डिसाइड वेदर कजन मैरिजेस वगैरह आर लाइकली टू हैपन एंड व्हाट आर द chances of getting children with cystic fibrosis. So you don't have to do it, but it is a recommended practice. It's for further information for their children for the future. And in some cases, in case the symptoms came at a later stage, then at least if sweat test is done, then we have actually picked up some children with CF who were asymptomatic, but because their sibling got diagnosed, they were tested and they were positive as well. So it's a recommended practice. One should do it, but it is not a must if you don't want to do it. If you think the children are normal, you don't want to do it, that is fine. But the recommendation is, yes, they should be tested.
Okay. Next question is from Salman Haider. Please guide about night sweats in CF kids.
Thank you. This is a question from Lahore. I can guess. So night sweats in cystic fibrosis. Now, there is no condition particularly that causes sweating at night in children more than anybody else. So it very much is environmental. Pakistani temperatures are high, and nighttime you are maybe blanket, maybe you're not wearing anything, but still closed room, the temperature may be high. So children may sweat, or even adults may sweat more during nighttime. If they got fever, they can sweat more. And we already mentioned they can have coughs and colds and chest infection that can cause it. And the other things to consider in Pakistan, which normally causes sweating at night, is TB. So CF and TB can coexist as well. And the other members may have CF and they may sweat as well. There are other conditions that can also cause sweats, and these are related to sometimes cancer, Hodgkin's disease, for example. And that's the way, rather than scaring people, the important thing is the children are checked properly for this. And Hodgkin's disease, just now that I mentioned it, they normally present with night sweats, failure to thrive, they don't put weight on, they get fever, they get infections, they get lumps and glands in the neck and the abdomen and the chest as well. And their blood counts are abnormal as well. To look at. So it's basically one of the cancer, and lymphomas there are varieties of lymphomas. Some are mild, some are serious. And children, when they happen, they are serious type and they will be picked up. But I think most of the time in children with cystic fibrosis, the sweating is due to the infections or the environmental temperature rather than lymphomas or any blood cancers.
Thank you. Next question is from Mr. Asher. Actually, he asked two questions. एक ये है कि क्या CF बच्चे को रेगुलर एंटीबायोटिक्स देना जरूरी है या जिस वक्त इन्फेक्शन हो उसी वक्त देना चाहिए?
So I mentioned in my statement earlier that prevention is better than cure. And certainly there are some antibiotics in certain parts of the world. So I'm saying some countries don't do it. For example, in UK.
So kindly, can you answer in Urdu because the question is in Urdu.
ठीक है, सॉरी मेरी उर्दू भी इतनी अच्छी नहीं है लेकिन मैं कोशिश करूंगा. जो ये प्रिवेंटिव एंटीबायोटिक्स होती हैं ये दुनिया में हर जगह पे इस्तेमाल भी नहीं होती हैं और हर जगह एक ही एंटीबायोटिक है वो भी इस्तेमाल नहीं होती है. यूके में फॉर एग्जांपल हम पहला साल या पहले 2 साल के अंदर हम फ्लूक्लोक्सिसिलिन एंटीबायोटिक है वो बच्चों को दिया करते थे क्योंकि इस एज में इस मुल्क में स्टफ ओरियस इन्फेक्शन जो था वो बच्चों को कॉमनली हुआ करता था तो उसकी प्रिवेंशन के लिए हम वो यूज किया करते थे. इन यूनाइटेड स्टेट्स अमेरिका में वो कैफेलेक्सिन एंटीबायोटिक हुआ करती थी आज से 30-40 इयर्स पहले. वो इस्तेमाल किया करते थे अपने लोकल कल्चर्स और बग्स के हिसाब से. लेकिन उन्होंने देखा कि स्यूडोमोनास के चांसेस ज्यादा वहां हो रहे थे तो उन्होंने वो कैफेलेक्सिन स्टॉप कर दी थी, इस्तेमाल करना छोड़ दिया था. हम भी ऐसा ही करते हैं कि पहले यूके में कि पहले 1 साल या कम से कम 2 साल के लिए हम जो है वो फ्लूक्लोक्सिसिलिन एंटीबायोटिक इस्तेमाल करते हैं ताकि वो इन्फेक्शन जो बच्चों को उस उम्र में होते हैं उसके होने के इम्कान कम हों. उसके बाद फिर डिपेंड होता है कि उनको रेस्ट कितने इन्फेक्शन कितने कॉमनली होते हैं और कौन से बग से होते हैं. तो दूसरी एंटीबायोटिक जो होती हैं वो भी इस्तेमाल की जा सकती हैं जो कि सेप्ट्रिन है या सेप्ट्रन है या कोट्रामोक्साजोल है वो होती हैं. जो अजिथ्रोमाइसिन है जो कि कॉमनली यूज होती है इसको एंटी इन्फ्लेमेटरी के हिसाब से अमूमन इस्तेमाल किया जाता है लेकिन इसके ऑब्वियसली एंटी बैक्टीरियल भी इसके असरात होते हैं तो ये प्रिवेंट भी करती है लेकिन एंटी इन्फ्लेमेशन के हिसाब से ये ज्यादा इस्तेमाल की जाती है और मेजॉरिटी ऑफ द पेशेंट इन द वर्ल्ड आर एक्चुअली यूजिंग इट. तो इसका इस्तेमाल करना हफ्ता में 3 दिन है वो इस वक्त बेहतर सोचा जाता है. आज मुझे पता है कि पाकिस्तान में टाइफाइड वगैरह का भी काफी चक्कर है. टाइफाइड जो है वो रेजिस्टेंट आ रहा है और लोगों को कहा जा रहा है कि एजिथ्रोमाइसिन इस्तेमाल ना की जाए. तो वो ब्लाइंड यूज ऑफ एजिथ्रोमाइसिन और पूरी मुल्क में बात कर रहा हूँ लेकिन सिस्टिक फाइब्रोसिस में ये सेंसिबली की जाए तो वो डिफरेंट सिनारियो है. तो ये डॉक्टर्स ऑब्वियसली जो लुक आफ्टर कर रहे हैं उन्हें भी थोड़ा सा सोचना है कि किस मकसद के लिए कर रहे हैं और क्यों कर रहे हैं लेकिन ऐसा कि ब्लाइंडली नहीं करना चाहिए. तो प्रिवेंटिव एंटीबायोटिक्स आर यूजफुल लेकिन उसके लिए आपको ये पता होना चाहिए कि उस मुल्क में इन्फेक्शन कौन से हो रहे हैं कौन से एंटीबायोटिक दे रहे हैं और उस बच्चे को कौन से इन्फेक्शन हो रहे हैं उसके मुताबिक और डिफरेंट एज के ऊपर हम डिफरेंट एंटीबायोटिक्स जो है वो इस्तेमाल करते हैं.
थैंक यू. इन्हीं का दूसरा सवाल ये कि क्या CF के बच्चों की फूक ज्यादा होती है नॉर्मल बच्चों से? सर अब अपने आप को अनम्यूट करें प्लीज.
आप आवाज आ रही है?
जी 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 ठीक.
तो ये जो बच्चे होते हैं जो एपिटाइट के हिसाब से इनकी एपिटाइट ट्रेडिशनली जो है ना क्लासिकली कहा जाता है कि उनकी ह्यूज एपिटाइट होती है. टमी जो है वो डिस्टेंडेड होती है जैसे हमने पहले भी वो डिस्कस किया और वजन साथ इनका बढ़ नहीं रहा होता है. ये चीजें पाई जाती हैं बच्चों के शुरू में. तो वाकई ऐसी बात होती है क्योंकि इनकी कैलोरी रिक्वायरमेंट जो ग्रोथ के लिए वो ज्यादा होती है क्योंकि ये अपना खाना अब्जॉर्ब नहीं कर रहे होते हैं तो इन्हें ज्यादा खाने की जरूरत पड़ती है. उस लिहाज से ये बॉडी का एक नॉर्मल मैकेनिज्म है कि मुझे खाने की जरूरत है लेकिन वो खाना क्योंकि हजम नहीं हो रहा होता है तो उससे प्रॉब्लम होती रहती है. लेकिन जब बड़े बच्चे होते हैं तो इन्हें खांसी होती है, चेस्ट इन्फेक्शन होती है, बलगम होती है और बच्चे अमूमन जो है ये बलगम को स्वॉलो करते हैं और ये बलगम जो है फिर चली जाती है मैदा में और इसमें काफी हाई प्रोटीन होती है. तो वो मैदे की जो सेंसिटिविटी होती है वो समझती है कि मुझे प्रोटीन वगैरह मिल रही है मुझे अब खाने की जरूरत नहीं है. तो बड़े बच्चों में या एडल्ट्स में ये एपिटाइट फिर कम हो जाती है. तो शुरू में ये उम्र ज्यादा होती है लेकिन बाद में ये कम हो जाती है। कई दफा बच्चों को खांसी के साथ वॉमिटिंग वगैरह भी होती है। जब वॉमिटिंग होती है तो बच्चे जो तकलीफ होती है तो बच्चा फिर खाना खुद ही कम साइकोलॉजिकली कम कर देता है कि ना मैं खाऊं और ना मुझे वॉमिटिंग हो ना मुझे तकलीफ हो। तो इसका मेडिकल साइड के भी है और साइकोलॉजिकली भी है, ये दोनों एस्पेक्ट्स हैं। शुरू में एपिटाइट ज्यादा होती है, बाद में कम हो जाती है, और वजूहात मैंने भी बता दी है।
नेक्स्ट क्वेश्चन है मिस्टर अली खालिद से, asking के they use bulb sucker after the mucus thinning medication in a CF infant. We can how but it does not help in taking out the mucus. So can you please guide about it?
मैं एक तो लफ्ज पहले आपके मिस कर गया था, दोबारा रिपीट क्वेश्चन करेंगे प्लीज।
They use bulb sucker to remove the mucus. I don't know how they using it from the nose on your, and they have an infant with CF. So how they are not being able to remove the mucus from it.
तो ये जो है ना वेरी सेंसिटिव क्वेश्चन, इन्होंने बहुत अच्छा क्वेश्चन पूछा है और इसका एक्सप्लेनेशन भी चाहिए। पता नहीं इस वक्त ग्रुप में कोई फिजियोथेरेपिस्ट हैं या नहीं है। तो ये मैं कहूँगा कि बच्चों में खास करके इन्फेंसी में जब बात कर रहे हैं, ये बच्चे होते हैं इनके लंग्स अल्लाह करना करे इतने डैमेज ना हो, इनमें म्यूकस वगैरह नहीं आता है लेकिन हो सकता है। Are you okay with me answering in Urdu or do you want me to revert to English?
Kindly answer it Urdu.
तो ये इस उम्र में भी जो बच्चों को अमूमन बलगम ज्यादा नहीं होती है, क्योंकि हमारी एक्सपेक्टेशन होती है कि इनके लंग्स इतने डैमेज ना हो, इन्फेक्शन ना हो, तो इनको जो है ना वो फिजियो करते हैं 2 दफा दिन में, तो कम से कम ये प्रिवेंटिव के हिसाब से होता है कि म्यूकस जमा ही ना हो। जब म्यूकस जमा होता है तो जब इनको खांसी आती है तो खांसी बलगम वाली महसूस होती है, वेट महसूस होती है, ऐसे लगता है वाकई बलगम है। तो उस सूरत में फिजियो करना चाहिए। और बच्चों में अमूमन ये होता है इस उम्र में कि जब फिजियो करते हैं तो जो भी म्यूकस या बलगम जो लंग्स के दूर वाले हिस्सों में होती है, वो जब टैपिंग करते हैं, परकशन करते हैं, तो वो सेंट्रल एरिया में आती है, जो कि फिर बच्चा जब कफ करना शुरू करता है तो ऊपर गले में आ जाती है और उसके बाद बच्चा स्वॉलो कर लेता है। तो ये जो एक्सट्रैक्शन है, म्यूकस एक्सट्रैक्टर वगैरह इस्तेमाल करना है, उसको सक करना है, तो ये गले की हद तक ही ठीक है कि अगर बच्चे को वो प्रॉब्लम हो रही है तो वो कर ले। अमूमन बच्चे ने स्वालो कर लेते हैं, लेकिन अगर वाकई थिक म्यूकस आया तो बैक ऑफ द थ्रोट आए तो वो कर सकते हैं, लेकिन मोस्ट ऑफ द टाइम जो है वो बच्चे खुद ही स्वालो कर लेते हैं और एक्सट्रैक्टर वगैरह की जो है वो जरूरत नहीं किसी किस्म में पड़ती है, सक्शन की जरूरत नहीं पड़ती है। लेकिन मुझे पता है पाकिस्तान में ये ट्रैकिकल सक्शन कॉमनली लोग करते हैं, उन्हें कहा जाता है हार्डली डन। ये इंटेंसिव केयर सिचुएशन में यहाँ किया जाता है, अमूमन अदरवाइज नहीं किया जाता है। और फिजियो वाले अगर कोई ग्रुप में है तो प्लीज मेरे बाद वो थोड़ा सा गाइड करें, क्योंकि उनका एक्सपीरियंस जो होता है वो सिक चिल्ड्रन ऑन इंटेंसिव केयर्स के ऊपर होता है और दिस इज स्पेशल टेक्निक है, वो ट्रिकिया में जाकर करते हैं। इट्स यूजुअली नॉट रिक्वायर्ड इन चिल्ड्रन एट होम who are able to cough। वो क्योंकि मुझे ये भी पता है कि लॉट्स ऑफ फिजियो जो है वो न्यूरो पेशेंट जो है उनकी लुक आफ्टर कार्य होती है, उनके कफ करने की सलाहियत नहीं होती है, लिहाजा सक्श करने की जरूरत पड़ जाती है सक्शन की। तो फिजियो चेस्ट जो है क्लियरेंस में खांसी अगर हो तो इसका मतलब है कि बच्चे वो अपनी चेस्ट क्लियर कर लेंगे, जब क्लियर हो जाए तो स्वालो कर लेंगे, तो अमूमन जो सक्शन जो है उसकी जरूरत नहीं पड़ती है।
Okay, thank you. Next question from Aruba Zishan. How severe is Delta F 508, or it varies from patient to patient?
So Delta 508 is one of the one which is associated with severe disease and pancreatic insufficiency. Like I said, not everybody with Delta 508 is the same. Some are good, some are bad. Even twins with the same mutation, they can be different. And the reason for being different is due to different reasons. One is their exposure. Two children, different age, maybe mixing with different age children at school, at nursery, they may be picking up different infections and therefore having different infection, although within the family, they may pass on to each other. Second, in addition to the CF genes, there are genes called modifier genes. These are genes within everybody who have influence on each other. And these modifier genes can be different in different individuals, and they can either control the CF mutation or make it worse. So it can be the patients with the same mutation, they can actually have different outcome. They can have different severity, even within two siblings. I know few siblings have same genes, but they are different. And that may be older. If for example, if you take adults now, they were born 40 years ago. Same mutation now will have better outcome because we got better medicine nowadays. So our interventions are different, gene modifiers are different, their environmental exposure is different, their nutrition may be different, and also their defense mechanisms, inherent defense mechanism may be different. And these can cause variation in the severity. So not everybody is going to be the same, but overall, delta F508 homozygous mutation is worse than some of the others.
Last question, second last question from Mariam Humair, and she's asking that my child has thalassemia minor as well. I just want to ask, would it affect her CF?
So just like cystic fibrosis trait, child is actually normal from the CF point of view. Thalassemia trait does cause minor illnesses or minor symptoms with the hemoglobin being on the low side, but otherwise they are not too bad and they don't need transfusions. If thalassemia children need transfusion, which thalassemia trait children do not, then they actually don't get problems with that, and it should not complicate their cystic fibrosis other than the hemoglobins on slightly low side. So if, for example, they were having chest infection, the hemoglobin's lowish, they may get a little bit more breathless than the other. But generally speaking, from infections point of view and other things point of view, it should not cause any worsening of their cystic fibrosis.
Last question from Rabia Imran, and she's asking that my child usually complains about leg pain. Is it due to vitamin D deficiency? What should be done?
So leg pains in children at the age Abdullah is can sometimes be what's called the growing pains. These are the muscles, fatigue, etc., and they can do it. Sometimes children, if you examine them, they may have what's called flat feet. The arch on the inner side of the foot is lost, so that when they put the foot down, their knees start touching and they lose that curvature. And that pulls on the muscles in slightly different direction than normally. So if they're running or doing something, that may cause pains in those children as well. So these are normal children without cystic fibrosis who can have leg pains as well. In cystic fibrosis, additionally, if nutrition is poor, the muscles are weak, that also can cause muscle pains, not only in the legs, but other body parts as well. And we know vitamin D can be low. This is one of the vitamins that we suggest CF patients should take. If they are low, then that can cause musculoskeletal pain as well. So it's a combination of these things can cause pain, leg pains in children. Obviously, if somebody's fallen and hurt themselves, there's the other reason for it. So in cystic fibrosis, vitamin D is an additional factor on top of the growing pains or muscle weakness or flat feet type people who can have the pains as well.
That's it. Thank you so much, Dr. These are we are done with the questions.
So it's taken us 1 hour 40 minutes on this occasion.
People started to ask questions quite late. Yeah.
That's what I'm saying is just from the timing point of view, I think we were being generous with our time. There was slight hiccups. We saw the last few minutes, but overall it was not too bad, I think. How do people, just as a feedback, if they are able to say over, one at a time, see how they found the session?
Okay.
How many people?
Actually, I've allowed them to unmute themselves. So if somebody wants to speak, they can unmute themselves and they can speak.
Sir, I would like to thank you and Ms. Zubia Hina and Talha for this session. It was very informative. Although we knew some basics about the CF, but today's session elaborated it in detail, and some of the questions which we had in our mind, you have explained very well, and thanks again for giving your time. This was Sunday and you actually have given your family's time to us, so it means a lot to us. Jazakallah. अल्लाह ताला आपको इसका अजर दें. जो लोग इस सारे सेशन को अरेंज करने में थे उन लोगों को भी अल्लाह ताला अजर दें, उनको सवाब दें और उनकी आसानियां पैदा करें सबके लिए. थैंक यू.
Thank you very much indeed for that positive note. I think there are about 25 people online at the moment. So if there are any other comments, as I said, even to improve, the way we can improve, some of the technical things we'll probably get better with and can still happen even we are at our best. But anything other than that, from the speed at which I spoke or English or Urdu or Jobia, if there's anything, please let me know.
Actually, a lot of people are writing their comments and they are looking quite satisfied and happy. So,
I'll stop sharing my screen because you don't need to see that anymore. Or you stopped it anyway. So no more questions from anybody? They're all feeling hungry and want to go and have some food?
I think we can end the meeting now.
Well, thank you very much again to yourself, Dr. Zubia, and also to Talha and all the other support workers. Is Ali there? Did I hear Ali?
I know, I think he wasn't able to join. He said I'll try, but he couldn't.
Thank you to him in absentia as well. So he wasn't there, but still thank you to him for facilitating and helping us. Okay, thank you very much indeed. Allah Hafiz, everybody.
Thank you so much. Thank you so much for your time.
We're going to meet in 2 weeks' time, and I'll post out, or we will post out the topic and ask more, invite more questions on that topic, inshallah.
Yes.
Okay, thank you. Allah Hafiz.